Welcome, everyone. I'm CITEE from NAMI, Wisconsin. Welcome to the Mental Health Action Partnership learning session on building the mental health workforce in Wisconsin. Somebody tell me if my sound is good. Yeah, it's good? Okay, great. I'm just going to go over the agenda and then we will jump right into the program. But before I do, if you would just take a moment to rename yourself with your organization and or your place and anything else you feel led to share in your tile. You can just hover over those little three dots in the top right-hand corner of your tile. And one of the options when you click those dots is to rename. And also we're recording this session. The session will be available. We will send it out to all of you afterward, and feel free to share it with other people. The Mental Health Action Partnership, for anybody who doesn't know, is a relatively new statewide broad partnership of stakeholders. It's a stakeholder-led coalition throughout Wisconsin. And the idea is to sustain ongoing system improvement across the system of care, across the lifespan and throughout the state. So we have these learning sessions just to level set amongst all of us and learn things we need to know from each other and about the work that the work that is before us. So I'm just going to go through the agenda. We'll have brief presentations from Kathy Markeland from the Wisconsin Association of Family and Children's Agencies. She'll do an overview of the mental health workforce, some national and state data for us and give us an idea of the kinds of strategies that are available and kind of are in the making right now. And then Ben Mompier from Wisconsin-Whitewater's CITEE program will go through the Qualified Treatment Trainee program, which is a program that helps get people in who have emerged from professional programs into licensure and helps to train supervisors. And then Shanna Sullivan, who is a licensed clinical social worker from Children's Wisconsin, will talk about their fellowship program, which is designed to increase the number of mental health therapists on the Children's Wisconsin staff. And then we're very pleased to have Joellen Steele, who's a licensed marriage and family therapist and the director of the Wisconsin Behavioral Health and Substance Use Services for the Lake Superior Community Health Center, which delivers services in both Wisconsin and in Minnesota. So Joellen will describe some of the behavioral workforce challenges of working on the Wisconsin side of a border community. And then we will dive into small group discussion. We have a set of questions, which I'll just say right now, and then we'll have a slide before we go into the work groups, but just so you can kind of have them in mind. The questions are, how does this information resonate with what you're seeing about workforce from your vantage point? And what's missing from this analysis that would be helpful in the mental health workforce work group as they move forward? So MHAP has work groups, and one of our work groups is on the mental health workforce. And then where do you see the greatest workforce need and opportunity? So those are three questions to just keep in mind as you're listening to these presentations. We'll break into whole groups for about 25 minutes, and then we'll come back and discuss what we found. And then we'll talk about upcoming learning sessions and adjourn. So with that, I would like to go to Kathy Markeland.
I am getting ready to share screen and hoping it's going to give me the option to share what I want to share. Okay, here we go.
Kathy, so there you go.
Yeah, I knew it was showing the wrong thing. Thanks, Em. All right. Thank you, everyone, for the opportunity to present with you today. Again, my name is Kathy Markeland. I'm the Executive Director of the Wisconsin Association of Family and Children's Agencies. For those of you that are not familiar with WAFCA, we are a statewide association representing private agencies that provide mental and behavioral health services across the continuum of care to families, children, and individuals. A lot of our member agencies are directly engaged with county partners, with schools, to provide for mental health and behavioral health services and supports, along with supportive services in the child welfare services space. So happy to be with you all today. And I offer all of that context as a way of saying we all have a different touch on what this work is and how we're engaging and thinking about workforce and the future of the workforce. And so eager for the conversation time for all of the expertise and experience that you all are going to bring forward from how your vantage point for viewing this work. So I'm just going to start with a little bit of demographic trends and really setting the Wisconsin context. So just a few of the things that we're all well aware of, that we have some demographic challenges in Wisconsin just generally with an aging population. We also have slowing population growth. We have declining fertility rates and reduced migration into the state and declining workforce participation. So one of the areas where we're seeing projected growth in workforce in the coming next decade or so will be in the 65 plus workforce. I think this data from our friends over at Forward Analytics, which is a research group that's attached to Wisconsin Counties Association, they compiled some data that was shared back in February 2023, just looking at where we see the total workforce. So working age population in Wisconsin is going to increase to 200,000 by 2030. However, the workforce participation rate is projected to be pretty much the same. So where we're at 2021 is where we're going to be at in terms of the total labor force that will be available to us in 2030. The size of the working cohort, so the workforce cohort of that 25 to 64 aged work group is going to drop by more than 100,000. As you think about who's currently employed within your organizations, who currently works with the populations that you're serving or that you're in touch with, it's just important to think about what that impact is for that shrinkage within that 25 to 64 aged workforce group. In the meantime, we're going to see this growth in the 65 and older workforce group. So for those of us who are looking ahead and thinking that maybe 65 is our time to step out of the workforce, I think part of my messaging here today is that we should be thinking about how we're going to pursue some encore careers and keep that work going post 65, because that's going to be a critical component of building our workforce going forward. Let's talk a little bit about the labor force participation rate, because as I noted in the previous slide, you have this differential between what is the working age, kind of the working age population is still growing over the next 10 years, but not everybody is participating in the workforce. So when we look at trending data about what's really impacting that, there's a couple of pieces that, again, has been called out by the work at Forward Analytics. One is sort of the drop off in work between that 35 to 44-year-old age group, and this is particularly true among women. So the median age of first child is increasing to 30. This is a nationwide trend. It's not just a Wisconsin trend. Nevertheless, you see during that time frame that 35 to 44 age group will be does drop out of the workforce or go to reduced work. Part of this is points to childcare needs, and we'll talk a little bit more about that during strategies of thinking about how we continue to grow workforce. But I think it's particularly impactful for us to be thinking about this when we look at who is doing our work within the mental health and behavioral health services space. We are heavily, when you look across the board, we are more representative of women and from a gendered perspective who are in this work. And so I think we need to have awareness of the impact of that and continued impact of what those differential childcare related items, how that falls differently on the different parts of the workforce. I think the other two things that are called out here are the continuing pandemic impacts. So I think that we would hope that we would start to see some of that tailing off as we move forward through the decade ahead. But there's really some pieces that I think that there's prediction that this is going to continue to have a ripple effect. It's changed how we think of the place of work. It's changed the place of work in our lives to a degree that people have set different parameters and boundaries and just a different life-work balance that people are thinking about. So that's another piece to have awareness of. And then finally, the impact of opioids nationally on workforce participation. It has a higher impact among men, but we still are seeing that that is really contributing to a decline in workforce. I think a particularly important point for our sector, again, because we are a sector that has the opportunity to have an impact on bringing some of those folks back into the workforce and really creating some meaningful workspace for people as well. And so thinking about where we have opportunity also in turning the tide in that space. I wanted to share a little bit about sort of national projections. This is way too small to read, and the links will be in your slides, but when you look at where the Bureau of Labor Statistics looks at growth, my primary takeaway I would offer to you here is that when we think about some of these occupations, these mental health occupations, that we're going to see projected growth that's growing much faster or much faster than the average growth of occupation. So Bureau of Labor Statistics sets a growth level of about 3% between 2022 and 2032. We have a cohort of jobs that are projected to grow anywhere from 5 to 18%. So faster or much faster than other occupations as we look across the array of sectors that are out there. I also want to note the data that we have around health professional shortage areas. So this is an area that you are all well familiar with, and just and looking at the map of where we actually have whole county shortage areas. The data that's shared here is actually pulled from recent budgetary analysis that the State Legislative Fiscal Bureau did in preparation for the 2023-25 biennial budget, but really identifying that HRSA estimates that an additional 56 mental health professionals and 130 primary care providers are needed to provide an adequate level of services across all the shortage areas. Of course, we know that this is not really reflective or representative of really the full scope that we see out there on the ground in terms of need, but this is really the lens that HRSA applies to really thinking about these shortage areas. And certainly when we look at that map, it's a lot of dark area across Wisconsin in terms of our shortage. So when I was preparing for today, one of the pieces that I came across was the National Conference of State Legislatures has essentially a rubric that they've put together to really think about how we start to break down what's happening within the behavioral health workforce, where states can pull levers. I have a personal bias, given where I have functioned professionally across my career has really been at state level policy advocacy. I recognize, and I'm looking forward to some of the presentations here following me that are going to talk more about how we do this at the organizational level, how we're pulling levers and in terms of organizations and in regions and in coalitions to really advance workforce needs. But this is a frame that talks about where there are policy levers that we could be pulling, again, primarily at the state level, not to dismiss anything that happens at the federal level, but this is one way to look at how we think about advancing policy to advance workforce in the state. So I'll just quickly note that there's these 5 categories that they highlight. I'm going to dig in on 2 categories and pull quickly some examples of things that I see happening in the state that I think are indicative or that represent taking up these strategies. And then I'd like to introduce some other things, kind of more food for thought around other strategies we should be thinking about and that we're interested in learning more from all of you about how you're using these strategies, either within your organizations or your regions. So a couple of things around understanding workforce needs. So in this bucket, we have kind of that study and planning area when we think about working on our behavioral health workforce. So we've had a number of studies here in the state, and we have a number of different ways that people have approached studying what our needs are. I'm I'm flagging here for everyone, and I'll talk a little bit more at the end about the governor's task force on healthcare workforce, which was just announced in the governor's state of the state in January, and which was just recently appointed. So clearly a short-term effort that will be taking place over the course of the next several months to dig in on what we know about the healthcare workforce more generally, and behavioral health will be clearly a component of that conversation. We had the governor's task force on caregiving, and they came out with their recommendations in 2020. I raised the governor's task force on caregiving as a resource for us to be tapping into when we think about what strategies we can pursue, because the studies that go on there that was really looking at the direct care workforce much more closely. And then of course, that whole array of informal supports, we call them informal supports. It's a term of trade, right? But it's really about family and those individuals who step into that role, whether that's a parent or whether it's another individual who takes on a caregiving role. And that happens a lot within our behavioral health sector, that there's a lot of people who are stepping in and providing those supports and services. And the governor's task force really talked about that broad, supportive, whether it's in that direct care, again, paraprofessional space, all the way to how we better support families who are giving of their time and their care, and to make that really build that into our infrastructure. I think as we talk about serving and supporting in our behavioral health space going forward, we need to make sure that we are flexing on all of those pieces of our families and others who are there providing support and care, and thinking about how we better step up to recognize that work. And then I also wanted to acknowledge that a way that the state has approached this pretty significantly this year has been through this past session, at least on the state legislative level, has been through thinking about occupational licensure. So certainly the task force on occupational licensure, there's been a lot of work around thinking about how we streamline people moving into professional work in this state, and ways that we can reduce some of the barriers for people accessing that work while still trying to balance protections for consumers, for individuals, and making sure that we are holding a standard around quality practice. Of course, and CITEE acknowledged that we're going to talk more about the Behavioral Health System Gaps Report, a really important report that came out in 2019 that provided us a lens on who's underserved. Where are we not meeting the need? And in part due to gaps in the individuals who are employed in our sector, whether it be peer supports, individuals, BIPOC, people of color, and really thinking about how we start to look at that diversity and equity question within our systems. So that will be another report we're drawing on. I'm not diving into that today because we have a session on that coming up in a future learning community. Then I just called out a few more reports that are coming not from the state directly, but that are resources that had been shared with you before. And so just those will be links that'll be available to you when we do the slides. So on the area of increasing supply of professionals, this is that second strategy bucket. We have items like promoting career pathways, promoting residency opportunities, and thinking about how we best support our emerging behavioral health providers. I've called out a few examples here. Ben's going to talk to you a little bit about the UW-Whitewater supports that are happening through the QTT program. There's also a program that has created an opportunity for people to move more quickly from the Associate's Human Services degree into a bachelor's in social work. So those kinds of examples where we see creating those career pathways, creating a clear line for individuals to keep moving forward in their education so we can grow a new cohort of mental health practitioners and therapists into the future. I also flagged out a couple of DPI related resources. DPI has been doing some really intensive work with some federal grants to really increase those care pathways. The DPI direct patient care pathway, I just would encourage you to take a look at that resource, which does help our secondary school students, so really starting in that middle to high school timeframe, to really create a mapping for them of if I'm interested in this kind of career path, what does that look like? And so it's crossing over all healthcare, but our behavioral healthcare services areas are represented there as well. And thinking about where there's opportunities for them in mental health technician space, where there's opportunities for them to move all the way. If they want to go to become a psychiatrist and what that looks like and how much school you would need. So I think that knowing those pathways are out there and thinking about how we better work with our schools and our local jurisdictions to help advance that and think about that as one of the pipeline pieces that we're promoting. And then also DPI has a federal grant to really think about growing their own. So I think this is another exciting space where we're growing that internal school mental health workforce support. And we're doing that through looking at people who maybe currently are doing special ed and have certification to provide special ed services and supports in school and want to keep moving on with their education. How can they earn and learn? And how can they keep moving that and grow in their professional career if they're interested in moving into school social work or school psychology? And they've been really thoughtful about building that forward so that it allows for people to grow into that space. Then I also want to think about how we're expanding careers in mental health more broadly. Where are we flexing on peers in the state, and where are we flexing on paraprofessionals as a component of our workforce, and really making that work a value long-term career path for people. So this is just a quick slide on who makes up the mental health workforce. We're going to talk a little bit, and I think our presenters today will be pretty focused on that mental health therapy space and really thinking about that post-master's development of LPC, LMFT, psychologists, and LCSWs. But clearly, when we think about this, we want to have that full broad scope, as I've been alluding to, around what is best and most supportive for people, and really meeting them where they're at all along any space where they're in need of a mental health or substance use treatment supportive service. Other strategies, these I just wanted to note very quickly for you all. So we have these other 3 boxes. The blue boxes are ones that, again, that the National Conference of State Legislatures call out. And I don't want to miss these strategies because we know that things are happening and advancing in the state in this space as well. We're expanding the reach of existing professionals by flexing on telehealth. Also have been looking very extensively at licensing out-of-state providers and moving forward with the compact work that has been happening at our state. So a lot of serious look at how we can make it more possible for people out of state to be able to provide for supports to people here in state, and also providing for, again, the right consumer protections and all of that as we think about changing. But we're certainly in a changing environment from a technology perspective. The second piece is really thinking about addressing the distribution of professionals. So this is that section that deals with the HRSA territories, right? When we think about where we have loan forgiveness and other things that happen from the federal level, there's a lot of states that are flexing on these similar kinds of programs and tools and tax credits. And so the national NCSL has a number of examples from other states of doing this. Wisconsin has been less in the space of using this strategy. I would say the QTT and some of the things that the governor has done under the ARPA opportunities have moved us more in this space for the mental health, for our mental health workforce. And then retaining professionals in the workforce is a huge piece. This is a part that I work with and talk to my members about a lot, that it's about keeping people in the profession. So what are we doing to really promote resiliency, thinking about how we're supporting their continuing education, their continued growth, and really providing for high quality supervision. All of these pieces help to retain our workforce and reduce burnout. So we want to be thinking about those retention strategies just as strongly as we're thinking about growing new providers. I added these 3 green boxes because I think these are really other important factors that all feed into when we think about workforce, right? Other ways to improve the work through technology adoption. I know working with a lot of community-based agencies, we can fall behind in some of this technology adoption space, and these are things that can make the work better. And so how do we think about flexing on what opportunities artificial intelligence brings forward? Thinking about electronic health records, interoperability. Those are pieces that the mental health and behavioral health space has fallen behind, where broader healthcare has been able to move forward, and that there's been some really proactive investment, and we don't have the resources always to do that. I am looking at time, and I'm wondering if CITEE thinks I'm going too long.
Yeah, if you could wrap it up, that would be fine. This is wonderful and rich information, though. So But
Okay, so
yeah.
I'm gonna get up on my last two soapboxes and then I'll step off. So my next two soapboxes are really around thinking about the target demographic. So I want us thinking about where we have the opportunity to flex on encore careers. How can we build work that's going to allow for people to come in part-time, people who may be interested in a boomerang career coming back to us to do some of this work, really thinking about how we better use lived experience and have that be a part of our array and have that be a part of our work. And then finally, healthcare finance is just a big factor when we think about the workforce issues across the board. So where is the fairness in terms of our reimbursement strategies and relative to where private healthcare coverage may be? So that, I think the last slide I had was on the governor's task force, and I'll just share really briefly that they're going to be wrapping up their work in September. So they just were appointed. There's going to be a lot of hot and heavy work happening with over the course of the next few months, and we're looking forward to helping to feed information to them around all of these strategies, and excited for what all of you will bring to those conversations as well. So I will leave it there.
Thanks so much, Kathy. And you can go ahead and take your slides down, but you know, that was really a lot of information. Just for those of you who want to know, we are sending these slides out. We are recording this meeting, so you can go over it in your own time, because that was a lot to absorb. That was absolutely wonderful. And now I'd like to move to Ben Mompier, who is the Outreach Program Manager for the Center for Inclusive Transition, Education and Employment, or CITEE, at University of Wisconsin-Whitewater. And he has been the program coordinator for the Qualified Treatment Trainee, or the QTT grants program. Ben, I'll throw it over to you.
Thank you, CITEE, and thank you, Kathy, for setting up. As Kathy alluded to the QTT program a few times in her presentation, it dovetails so nicely into those trends in the workforce and what we're doing with the QTT grants program into building the mental health workforce. So thank you all for having me. My name is Ben Mompier. I'm a social worker at heart, and I get to do a lot of macro practice. Helping the helpers in coordinating the QTT grants program has really grown a lot over these last few years. It keeps me pretty busy. So it has been a great adventure, and thank you for having me today. So I'll just try and give a quick overview of the QTT grants program, kind of go over the types of QTT grants that we've put out there. We've tried to get at the workforce development in a lot of different ways. And another unique part of the program is all the professional development offerings that we're able to provide through the QTT grants program. And just going over kind of some of our implementation approaches and outcomes that we've seen from the program in our time doing the program in these past few years. So first of all, just define what a qualified treatment trainee, QTT. Not everyone is always familiar with that term. It's those graduate, postgraduate level mental health workforce workers that have the advanced clinical licensure, but require the 3,000 supervised hours. So those CAPSW for social workers, LPCIT, MFTIT going for those 3,000 clinical hours, and really supporting agencies in hiring and retaining those positions to ultimately have more clinicians reaching those advanced clinical credentials in the field. So we really try and distill the goals of our program that we go at with all of our different programs into two big goals, and that is to increase the number of QTT positions available in Wisconsin and invest in that QTT supervisor development. And I'll talk a little bit more about why that's such a unique opportunity a little bit later on. The program is now in its fourth fiscal year in FY24 here. It was created back in fiscal year 2021. I was excited to see Shanna Sullivan on the call today too, from our first fiscal year joining us, and all the way to today. And it's grown a bit through the years. Kind of the latest bit of funding, it was originally funded through the state statute bill and through general purpose revenue, but we've seen also additional funding through the latest in FY23. Tony Evers announced a $9.1 million award to out of the American Rescue Plan Act funding to expand upon and enhance some of the programs of the qualified treatment trainee and build educational pathways into these qualified treatment trainee positions. So going over the types of grant programs that are offered, I'll start with these two. These are really our main programs that the QTT grants program holds each year. This was what was originally started back in the beginning of the program under the statutory funding. And the first is the Emerging Agency Award. And as you might expect, those are agencies that are emerging into hiring those postgraduate QTT positions. They might have organizational preparation they need to do to add on that position, whether that's maybe some supervisor training to get a clinical supervisor in place at their agency to hire and retain QTT positions in the future, something like that. The Expanding Agency Award is kind of our flagship program, if you will. Those are those agencies that are already doing it and are trending up in their hiring. So we hope that this builds the supervision capacity at those agencies with these direct grants to do the Expanding Agency Award, and that they're adding on additional postgraduate QTT positions during their time with the program. The second slide of programs is a lot of the programs covered under the Treasury ARPA Award that I mentioned previously. And this really opened up the program to where we went to a lot of different places in the workforce pipeline. We kind of talked about the QTT pipeline. And we had a lot of interesting offerings on, educational pathways and the graduate students. So that was one award we went to, was the graduate level QTTs. That kind of identified burden of the clinical internship time, and student loan payments. So these kind of operated as a scholarship of sorts, but it really was tied to those clinical internships at accredited programs for those graduate level QTTs when they're completing their masters to ultimately become the postgraduate QTTs. And then I'll skip down to the bottom one because it's somewhat related, is on the educational pathways, is the Human Services Pathways program. We've been working with our technical colleges on developing a Bachelor of Art and Applied Sciences, or what the BAAS stands for there. And some of those degrees, we worked with our partners on reworking those to basically better serve into bachelor and master's level social work educational pathways, so that more people going to our technical colleges could then pursue on to bachelor's and master's level degrees to ultimately reach advanced clinical licensure around the state. Two other unique programs that were funded under the Treasury ARPA were the co-occurring disorder treatment training grants. We're looking at the kind of crosswalk between the dual diagnosis or treatment of co-occurring disorders is what we've further operationalized it as, that crosswalk of mental health and substance use. And looking at additional professional development offerings, there's been some changes in the credentialing process for co-occurring disorder treatment. So a postgraduate training program in professional development. We were proud to work with trainer Ted Isidore to develop the 4-step approach to treating co-occurring disorders training. And that actually is available now through June for free to the public to register for. So we really encourage people. It's a self-paced course hosted on our campus at UW-Whitewater. So we would encourage people, if you are in that realm at all of substance use treatment or treatment of co-occurring disorders, to register for that. And lastly, the culturally responsive grants really supports agencies in the implementation of culturally and linguistically appropriate standards. If you're not familiar with that, that really relates service delivery to culturally and linguistically appropriate care. So the tie-in with QTT is obviously recruiting and retaining staff that might best meet the cultural and linguistic appropriate needs of your service area. Might involve recruiting perhaps a bilingual QTT that will best serve those communities in the preferred language, or something like that. So that's really the crosswalk between the implementation of the class standards and relating to workforce development and QTT. So another piece of the expanding program, and obviously the co-occurring, we've developed a lot of professional development offerings through the program, and it's definitely a key piece to the QTT program. But kind of our main offering of that expanding agency grant, there is the QTT Supervision Professional Development Initiative, which just runs for 6 months while for agencies that have received the grant. So we really get to tap into those clinical supervisors around the state for professional development. And The reason for that is kind of showing this logic model on this slide, that we really view the parallel process between clinical supervision and client outcomes. And kind of how we get there is that the clinical supervisor is that key linchpin in developing trainee skills, and that really goes to the clinical service delivery taken out by those QTTs. So we really think that there's a connection between working with clinical supervisors to increasing trainee skills and ultimately the client outcomes, with that increased quality of clinical services being delivered all around the state. So it's a really unique opportunity. Each expanding agency picks a designated supervisor that participates for the 6-month initiative. We have monthly community of practice meetings, and then if supervisors are still interested in staying plugged into the community, we have an alumni learning community. So we have, now that we're 4 years in, we've had several cohorts kind of graduate to the alumni learning community, and there's still a great cohort that's keeping ongoing learning of clinical supervisors around the state. And we get such positive feedback on this of the skill-based focus. It's very easy to get drawn into the administrative tasks of supervision. So that's so good to talk practice, and just the collaboration with other supervisors. That's the other thing we hear all the time, is becoming a clinical supervisor actually becomes kind of a lonely position, that you don't get the chance to collaborate a lot of the times with other supervisors around the state. So it's such a cool opportunity that we bring together clinical supervisors from all around the state. I'll just briefly cover our implementation approach too. This is we are really doing the National Implementation Research Network. Check them out if you haven't already. And we really just try and tie in a lot of things through our professional development offerings of utilizing data systems. We do the supervision experience survey, which relates to the supervisory, like working alliance and rapport, and then the checklist, just what is happening in supervision sessions around the state. And we do this, along with the ongoing learning, to give feedback to the supervisors so that they can get an idea of what's going on. The systems intervention really comes in just from the kind of financial support of the grants themselves, to we look at organizational readiness and productivity standards for who are these agencies that have bought in on expanding QTT service delivery and adding these QTT positions. So could go on more, but that's just kind of our implementation approach of tying together some of these implementation drivers into our program. And we've seen a lot of great outcomes from the program, with this great expansion of the program, the Expanding Agency Award. This is just a few of our numbers from the expanding program, but there's a lot more if you look into our annual reports are on an upcoming slide. So definitely dive in more if you are curious for more. But, we see to the tune of, 168 QTT positions across 137 expanding agencies last year. So we really have gotten to expand at a lot of different agencies, and kind of how we operationalize the expanding is a increase over the average of the previous 2 fiscal years. So the total number of positions retained, it shows that those agencies are trending upwards and adding these QTT positions. And of course, we have more and more supervisors. Just visualize there of just the number of supervisors that have participated. One thing I didn't get into on a previous slide is that we also have the continuing award. So that's really the only reason it's trended down. We actually had more expanding applications, but the new supervisors, we also have a 2-year model that continuing supervisors can continue onto that 2nd year. They don't necessarily participate as a new supervisor. So we still have had actually an increase in the number of expanding awards each year and applications. And so we just have less sometimes new supervisors. And we certainly look at the priority areas that Kathy highlighted. Sorry, now I'm going just a tad over time here, so I'm just going to try and wrap up really quickly. But we make a really big emphasis on statewide-ness of the program, and Kathy highlighted those provider shortage areas. So we do always try and look at awarding to those agencies that are in those more remote areas of the state, and we do achieve that. Different size agencies you can see is portrayed on the map on the right, that we have anything from agencies that are smaller agencies, where it's one person, that's the owner, operator, supervisor, to larger training agencies that might train, 20 QTT positions and at a time. So we really see the variety represented within the statewide-ness of the program. So I think that's just about all I have for today. If you are curious for more, our annual reports, a clinical supervision matters reports that covers a lot more of our professional development initiative and our supervision materials. If you are curious for more, I would encourage you to check out some of these links. And that last link is that co-occurring treatment training grant, or just the training offering that you can register for free now through June. So thank you all so much. Here's our contact and main website as well if you are curious.
Thanks so much, Ben. That was really informative and encouraging. It's wonderful to see this program ramping up around the state. And clearly, there's more room for continuation and growth. So now we're going to turn to Shanna Sullivan with Children's Wisconsin. Shanna is a registered play therapist supervisor, and she also supervises the school-based mental health Milwaukee project. But she's going to describe a fellowship program in Children's Wisconsin designed to increase the number of mental health therapists on their staff. Shanna.
Yes, thank you, CITEE, and good afternoon, everyone. As we gather together on this Friday afternoon with beautiful weather here in Wisconsin, at least where I am in Milwaukee. As CITEE mentioned, I am Shanna Sullivan. I work for Children's Wisconsin. I've been with Children's Wisconsin for over 15 years, most of that time as a clinician myself. And then in 2019, I was able to join the team that launched the Therapist Fellowship Program, which is a program designed to develop and support master's level clinicians in earning their 3,000 hours towards clinical licensure. Back in 2019, which seems like a lifetime ago before the pandemic, right? In 2019, when Children's announced a $150 million pledge to improve access to mental health services to kids in Wisconsin, we knew the greatest challenge would be the workforce and hiring the needed providers. It's been a challenge that we've had for a number of years. And so this was one of the first areas that we invested our time and resources in. The Therapist Fellowship Program started out very small with just 5 trainees in 3 clinics across the state of Wisconsin, which was made possible with a generous donation from the Bolt Corporation. We started out as a really unique program within our mental and behavioral health departments with this cohort of individuals, who we trained and mentored and, were alongside as they stepped right in and began to treat kids and families as qualified treatment trainees. We created individualized development plans and provided the additional training that they needed for pediatric mental health care, because most master's level clinicians don't really get enough of that in graduate school programs, which is another area of attention when thinking about pediatric mental health. And so 5 years later, currently we have 10 QTTs who are either working towards their hours or have achieved their hours, but are waiting clinical licensure, and 27 QTTs that really completed the program and completed their licensure and are licensed clinicians in the state of Wisconsin. And so much of the clinical support I was able to provide as a supervisor did come from the privilege to be trained by the UW-Whitewater QTT grants program. So thank you, Ben. It's great to see you today. But along the way with this program, I've learned a lot personally, and I think as a system, we've learned a lot of important lessons. And, I'm just going to talk for about the next couple minutes, 5 minutes or so, just about some of the most important lessons that we learned along the way and, where we go in the future. So I think probably really importantly, along with any of the work we do, flexibility and agility is really important. We started out with this plan to have this therapist fellowship program, and we had to adjust and pivot and reinvent. We had a global pandemic along the way, which changed a lot of things. But I think, the plan that you start out with for your workforce demands is not going to be the plan that you end with. And to have that flexibility to really be able to lean in that and kind of move along with what's happening in the workforce, as we saw when Kathy was really just talking about all the trends and the changes that are going to be happening in the next few years. I think along with that, really listening to the workforce, incorporating the feedback that your trainees or that your workforce is really giving for their experience working in mental health care. What is working, what's not working, what are the learning opportunities, what's happening in the world and culture that you have to adjust to. like many organizations, we had providers before the pandemic that had never even thought about working from home. And, you know, once we were all sent home, they kind of said, hey, wait a second, this is working for me. How can I make this a part of my everyday life? And so we had to adjust and come up with a plan to meet that need. You know, working with QTTs, one thing I've had to learn personally is really taking some time to understand the generational needs of a workforce who's new to the professional world. You know, their expectations and needs for employment are different than mine. I've been in the field for over 20 years. And so learning about Generation Z and learning about how skilled they are at expressing their needs for professional satisfaction and well-being and belonging in the workplace, you know, that's something that I had to step back and take some time to really understand in supporting a generation of individuals who are new to the workforce and, you know, really eager and excited to start working with mental health, but also maybe needing some support and understanding what kind of well-being and resiliency support is needed for this very difficult work, because along the way in the pandemic, you know, the mental health needs change for kids and for families. So how do we stay curious and open to learning in that area as well? And I think finally, probably the most important thing that I've learned is really to invest in a strategy for inclusion and diversity. We know that mental health needs are rising, but in the pediatric world, we also know that the number of kids under the age of 18 who identify as multiracial or as BIPOC, Black, Indigenous, people of color, you know, those kids, the numbers are rising. I think it's over 50% of our kids under the age of 18, you know, identify as multiracial. And we need to have a plan with our workforce to really support those needs. You know, ideally, we'd have a workforce that's representative of this, but this is a challenge faced by many of us on this call in building our workforce for a variety of different reasons. And so that investment in inclusion and diversity really starts well before hiring and continues throughout employment and retention to sustain the workforce. One thing that we learned is that there's so many barriers that the BIPOC community experiences that get in the way before they all even get to your doors. And so having a clear plan for how you're going to recruit and how you'll welcome not just diversity in the workforce, but diversity in thought as well. That's something we really need to be prepared for. So since the inception of our therapist fellowship program, we've managed to train and support 37 therapists in working towards or gaining clinical licensure, which is way more than we set out to do. We had the goal of 25 therapists over a 5-year period. Last year, we made the decision as an organization to kind of shift from being a standalone program to integrating our therapist fellowship program to the rest of our mental health programming, simply because we just couldn't keep up with the need and the demand that we had for new trainees. And so we no longer have a standalone program or cohort. We hire trainees directly into licensed positions to allow us to keep up with workforce demand and to be flexible and agile and really have more choice in where we place QTTs. We've expanded our training to support all of our clinical supervisors so that we can keep up with that workforce demand and provide that support that's needed to really develop their skills. And we'll continue to be flexible and agile and keep shifting as we go so that we can keep providing kids with the best care we can. 5 years from now, things will probably look different, and this will be a different conversation with this group, but I am thankful to be here today to kind of share that experience with you all as you are stepping into planning and thinking about what is going to be relevant as we move forward. So thank you for having me here today. I'll kind of turn it back over to CITEE for our next steps, and I hope you all have a wonderful weekend.
Thanks so much, Shanna. I mean, that was really inspiring. And it's lovely to see the thread from what Kathy said through what Ben said through what you're saying. So much appreciated. And I know you have to take off, but we will collect questions for you and send them to you after the session.
Yes, thank you all.
Thanks so much. And now we're going to ask Joellen Steele to talk to us about the challenges that she and her colleagues face. Joellen is a licensed marriage and family therapist. She's the director of the Wisconsin Behavioral Health and Substance Use Services for the Lake Superior Community Health Center, which delivers services both in Superior, Wisconsin, and in Duluth and in surrounding communities. So they bridge both sides of the border. So Joellen's going to describe some of their challenges, and we'll just see where it goes from there. Thanks so much, Joellen.
Yeah, as she said, I am the Director of Behavioral Health and Substance Use here in Superior. And just for a little background for people, if you don't know kind of how we are geographically, Superior and Duluth are actually often called the Twin Ports. There is literally just a bridge that separates us and the St. Louis River. So if you think of like down by Red Wing, Minnesota and like that area. So we have services on both sides of the bridge. In Wisconsin, we have the AODA. There is not a substance use program in Duluth. So a lot of our challenges come down to hiring staff. We are currently down to 3 therapists, including me in Wisconsin. We have a wait list of around 400 people usually at a time. And we have 2 substance use counselors, and we also have a wait list for that. Within Superior, there are not many providers. There's a couple of other private practice places. Essentia is the big clinic system here in Superior, and they have a therapist or 2. They do have a partial hospitalization program for adults, but there is not much of anything for kids. Northwest Journey recently just opened up here again for day treatment. So where this ends up playing out for us is it really boils down to like the Medicaid rate. So Wisconsin's Medicaid rate is far lower than Minnesota's Medicare rate. So what that does is it ends up hurting clinics that are practicing in Wisconsin because the Medicaid rate is so much lower and you can't take clients. And where it also hurts us is our primary Essentia, St. Luke's, the behavioral health units, the day treatments, all of that is in Minnesota because there is not the population patient volume in Superior. Superior is 26,000 people. Duluth has 85,000. And when you get outside of Superior, it gets pretty sparse pretty quickly. On the outskirts of Duluth, there's Hermantown and Cloquet. There's still some pretty populated areas around Duluth. So a lot of the places in Duluth do not take Badger care at all. There is nowhere for us to get psychological testing up here at all. And we now are unable to even refer kids for partial intensive outpatient partial hospitalization because you need to be in the Essentia system. So that ends up kind of where we can't get therapists to work over here because they'll go into private practice in Minnesota and it's cheaper or they make more. But the other part of that is it can be really hard to keep therapists here because you end up burning out. So like here at the clinic, we see underserved, uninsured, underinsured, and substance use. And so it's really intense clients, really intense needs, high needs, and we have nowhere else to send them. So when you have a person who is intensely suicidal all the time, making threats, hospitalized over and over again, there is nowhere to send them. You're it. There's no case managers up here. We don't have CCS. So it can be really hard. You have to really be dedicated to the population, which most people are, but we all have limits of what we can endure and get frustrated with. Because of the Medicaid rate being so much lower, wages are lower over here. On average, we are about $10,000 to $20,000 less than most other community health centers. We are an FQHC, so we are able to have PPS rate, but there is a lot of other stuff that plays into that. The one other thing that is troublesome for us as far as substance use, because I know we're talking a lot about behavioral health and like the QTT, we're able to bill QTTs as an FQHC pretty easily. It's getting the QTTs here that is the harder part. But for SUD, Wisconsin does not have reciprocity with Minnesota for licensure for substance abuse counselors. In Minnesota, the LADCs are not able to come work in Wisconsin. And so therefore, where we are at, The substance abuse counselor program is pretty small here at the Tech College at Northwood Tech. And so there isn't a lot of people coming out of that program. And when they do, the level of supervision that is needed is 2 hours a week per staff. And that is a lot of supervision for any like director to be having to do. I've brought this up with DSPS, but it boils down to a test that they have to take, even though Minnesota LADCs require far more education. So these are kind of the things that we run into because there are a whole plethora of LADCs over in Duluth, but none of them can come and work over here. So we have to try to find people within our community. So that's kind of some of the big things that we encounter.
Thank you, Joellen. I'm sure that a lot of people on this call can relate to some of those challenges, but you certainly have your hands full up there in Superior. So everyone, we're going to go into breakout groups to just sort of to chew on all of this, and we'll stay in the breakout groups until 3:45. And here are some discussion questions, and we'll put these in the chat, but how does this information resonate with you, with what you're seeing about the workforce from your vantage point? And what's missing from this analysis that would be helpful to the Mental Health Action Partnership Workforce Subcommittee as they move forward? And where do you see the greatest workforce need and opportunity? So just think about those 3 questions as you go into your work groups. There'll be a facilitator in each work group, and Mary Kate is opening those work groups now from the breakout rooms here. So let's just take a few minutes between now and just a couple minutes before the hour to just talk about this as a whole. What did you take away from your breakout sessions? What really kind of resonated for you? I'm going to start with Renee, if she's here. Yeah, there you are.
Oh, you wanted me to start the report out. I think we determined Stacy was going to report out on our group.
That's good.
I'd be curious to know how the other groups picked for who would report out. But anyways, good afternoon, everyone. Our group, we just really wanted to thank NAMI for giving us this opportunity to bring people together on this effort across the state. Really, we didn't have, I think, any huge ahas. It was really to know that we are all working towards the same end, but until we figure out a way to get more young adults into the pipeline, that it will really be a hard balance to, we have all these shortages in providers. We know that it's statewide. There's very few areas that have good coverage, but at the same time, if programs are only graduating a handful of people, and there's all these barriers to getting those hours and things, that we have a long road ahead of us trying to balance that need with the number of bodies that are available, and very long wait lists, regardless if you're in Superior or Dane County. I mean, it's happening everywhere. So we didn't really have any huge aha takeaways, except that we are here together, and we need to figure out how to bump that number of bodies up and work together. So that was it for our group.
I'll add one more layer. Brenda made a really good point that some data we need to understand is who is doing the work and where are licensed, LCSWs, LPCs, LMFTs, where are they working, what are they doing, and who's doing the work otherwise? Who are the case managers? Who are the therapists? Who are the service facilitators? Who's doing what? And if we could understand that might help us understand what we might need. What of those licensed folks are retired, like Kathy Markeland mentioned, and what of those licensed folks are doing other jobs, like me?
Excellent points. Yeah. Group 2, who's going to report? I think Emily was in that group. Emily Coddington. Oh, nope. Okay, who's in group 2? Anybody?
I think that was us. Am I right, Julie? Yes. And so I will just report because I took the notes. We didn't really come up with someone to report, but one of the things that we discussed was how the QTT and the training process, that for some folks it's more the regulations that makes it cumbersome to do supervision and training, and not necessarily just the training itself or the time from the supervisors, but actually the regulatory process to do that. The regulations make it cumbersome. One of the other things that was brought up was the recent closure of HSHC, and suddenly we have lots of providers and then a hospital just closes. And what does that mean to a community? That's very scary for those that are in that area, especially for one that, looked good on that map that Kathy showed. And then suddenly there's a closure that has very little to do with the providers in that area and more for a systems issue. On what is missing, one of the questions we had for data group would be, how many people are actually going into mental health? Is there the same number of people going into the mental health service systems in college? But one of the funny things, aha moments we had as a group was we all know either children, colleagues, or friends who majored in psychology and got done with that BS in psychology and didn't know what the heck to do with it and went into something else. And our colleges and schools not doing a good job of explaining or giving the avenues of social work to MSW that's a psychology degree, or psychology, that what avenue. Like, I know all of you in there in this space have known kids or friends or colleagues who majored in psychology and got done and said, okay, what am I going to do with this, right? A BS in psychology. So is there a better avenue in that process? Why are we having so many kids go into, obviously there's an interest, but not a knowledge or a path that's given to them that makes it more streamlined of how you can become licensed in an area that you can work in. So we feel like that's a big miss on the college levels. And maybe I'm overstating it, but I think we all agreed and laughed at, we knew so many people with that. And then where the greatest need, one of them was the workforce. Right now there's so much kind of a demand from people that have licensures that they can kind of, they want to work remotely. They want, because they can, there's so limited of them that there's trainees accommodating them to their needs. But the opposite of that is really, or fighting with that is, that's great for doing therapy and online for depression and anxiety and things like that. But for those living with serious mental illness, those accommodations are very difficult for the training process, because we really do need people to not, we need people that are there, that are being able to be there for a part of the training for people with serious mental illness, because you may need to be going to their houses, you may need to go to the hospitals, you may be needing to go to clinics or to their homes, and that training process, there's a loss there, especially for the wraparound services in the States. And so, that's something that is difficult to provide, that accommodation where people can work comfortably remotely and whatnot. But then how do we service the people that are at greatest serious needs with those accommodations? So those were some of the comments in our group.
Thanks a lot, Mary Kay. That's a lot. Group 3, who was in group 3?
That was our group, I think.
Okay. Oh, okay. All right. Well, I'll report out. And the rest of you, please chime in. We kind of really focused in on leveraging technology, both in the AI space and then in the record keeping space, and noted how expensive things like Epic are. And maybe there are ways to do economies of scale to allow smaller agencies to take advantage of those technologies that are so time saving and that relieve the documentation burden that weighs people down so much. And then we had another big discussion on peer support specialists and how that's a way to increase the mental health workforce, one segment of the mental health workforce that provides, really valuable quality time, and also community health workers who may be dually trained in general primary care as well as mental health and substance use care. So using the kind of paraprofessional level, scale up, and how functional our current system is with peer support specialists, and that there's lack of coordination in between the people who want to work, who get trained, and then the people the agencies that want to hire them. We need much more coordination, which doesn't seem like it should be feasible to do better coordination and to have more training opportunities out there so that the people who want training can get training and get matched to jobs, and then can get supported in those jobs. And then if they want to go on to another field in the mental health workforce, that they would have the opportunity to do so. What else am I missing, group 3?
Well, it also includes the living wage for peers.
Amen. Yes. Yeah. Because many people want to go into this as a way to get off benefits, but if you can't make ends meet, that defeats the purpose. Okay, group 4. Who wants to report from group 4?
I don't think we met. Unless I was supposed to be the facilitator, but I got put in group 3.
Okay.
Some of our breakout rooms changed, so group 4 would have been Michelle or Emily.
Yeah, this is Michelle. I can relate back. We talked about there being a need for more centralization and the barrier of border states, basically. Carlos was talking about some work down in southeastern Wisconsin about, there's folks in Illinois that could help us with this problem. And there's been some good advocacy to legislators about fixing that barrier, but apparently nobody legislator can actually agree on how to solve the problem. So there seems to be lots of discussions and a lot of disagreements at that level about the best approach to solving, those cross-state boundaries, barriers. We talked about how, folks who just graduated, it's really hard out there. It's the age-old question of you want to get a job to get experience, but you need experience to get a job. And, needing people to take a chance on new graduates. We talked about, in Milwaukee, there's high need, but there's also quite a bit of resources. And there's some great work being done there by Leanne to really look at how to redesign the crisis continuum, how to break down silos between public and private organizations, dealing with, better referral processes. And what we heard in that group is that there's room for a lot of hope there, because people are realizing there's no need to hoard a wait list. There's plenty of folks that need help. And there seems to be, shift on the willingness to work together there. We talked about the importance of medication management, especially in rural areas, using things like telehealth, bolstering primary care physicians. I gave a plug for the Wisconsin Child Psychiatry Consultation Program as one example of that. We talked about integration within and, without FQHCs, federally qualified health centers, but there's lots of billing challenges. There was an interesting discussion about Wisconsin's licensure standards and maybe right sizing them a little bit. I'm paraphrasing here a bit, but we talked again about the state border. There's qualified folks in Minnesota that can't practice here, and there may need to be I believe the phrase was a come to Jesus moment, to be a little bit more pragmatic about what the right level of licensing standards is on the part of professional organizations, understanding that there are some turf war potential turf war issues there. And also talking about how credentialing for Medicaid is a nasty problem, with examples of, providers that have 10 to 13 different managed care systems that they have to work with. And I believe that's most of it, but happy to hear from the group if I missed anything.
I just want to chime in. I used to work for the local school district for many years, and one of the issues with education was the same issue, licensure. You cross the border, you cannot teach, and the DPI came up with a nationwide licensure. So that is a model that has been applied to other professions, and it could be applied to this profession. You get a national, I don't remember how they call it, but it's like highly qualified teacher, I believe is the name. So you could teach anywhere in the country, or at least in any state that signed into that. So that is a possibility. It has to deal with a lot of, red tape, but it is a possibility also for mental health services.
Thanks so much, Carlos. I think there's one more group that hasn't yet reported. Mary Kate, who's done that?
I think that's ours.
Oh, go ahead, Kathy.
We didn't designate a reporter. But I see Mark's unmuted too. A couple of things that I'll reference from our group since we're running at time here. I think one of the pieces was talking about, that 65 plus cohort, other people who may be looking to make a transition during mid-career too. So how are we tapping into that channel of people who maybe got their psychology degree, got lost and couldn't figure out what they were going to do with it, and are interested in coming back into the workforce and into providing support from a therapy perspective and helping people channel their way back. We also, I referenced sort of talking about how we increase capacity by helping people practice at the top of their license. So using that as a gold standard for how we think about growing the workforce and really expanding access for people. We also talked about the fact that in northeastern Wisconsin, it was shared with us that there, among all of the counties that participate in the Northeast region for the DHS region up there, all of them have vacancies right now for mental health therapists that they can't fill. So it's, that's the sad reality, right, of the gaps that we have between what we need and who's available to do that work. Anything I missed? A lot from our group. We talked about BIPOC clinicians. We talked about how we provide for those learning opportunities and really work collectively. In some instances that maybe when we have local students that need internships, that need those supports, how we can support one another to do that, because not every agency or organization is capable of providing that support or on an ongoing basis. But how could you do that and share that resource with each other so that you're helping to keep those local students local and hopefully move forward in the work in the region.
Thanks, Kathy. Wonderful, wonderful discussion. You all very rich. We've got this all recorded, as I said, and we are going to be taking notes, and we will send out the slides and the recording and a summary next week. Before we leave, I just want to invite you to the next MHAP learning session, which will be March 15th. That's another Friday, and it's at from 2:30 to 4 o'clock again, and we will be introduced to the Advancing Behavioral Health Initiative, which is closing up its 8th year working with local behavioral health coalitions, and they have learned a lot. So we will learn from them, and we'll have several of the people from the 10 coalitions around the state with us, along with Dr. Michelle Broadus, who has been with us today, who was the principal investigator for that project. And then on April 19th, we are delighted to welcome Dr. Abra Vigna, who did the 2019 behavioral health gaps analysis that really spotlighted disparities in Wisconsin's behavioral health service delivery structure. And we'll have a panel of respondents to kind of reflect on what's happened since 2019. And if you have other topics or ideas or recommendations, please email Julia And we'll also be gathering them through the general MHAP communications. So that's it, everyone. Have a wonderful weekend, and thank you for coming and for sharing everything that you know and everything that you need with us. And we will digest this and work together. Thank you, everyone.